There's a number that almost every adult over 50 has memorized: 120/80. It has been repeated in clinics, in waiting rooms, on health pamphlets, on television, and at kitchen tables for decades. It is treated as a universal standard, the gold standard measurement of healthy blood pressure for every human being at every age, in every condition. And for seniors, that framing is not just incomplete. For many people over 65, chasing that number has led to real harm. Here is what the research actually shows. The relationship between blood pressure and health in older adults is not a straight line. It is not a simple equation where lower always means safer and higher always means dangerous. It is a complex, individually variable balance, one that leading cardiologists, hypertension specialists, and international medical bodies have spent decades refining their understanding of. The 120/80 standard was developed primarily from research on middle-aged adults. It was never meant to serve as a universal target applied identically to a 45-year-old and a 78-year-old. And yet that is how it has been communicated. That is how it has been absorbed. And that gap between the simplified public message and the nuanced clinical reality is the gap this video exists to close. Today we go through what the research actually says about blood pressure targets for seniors, what the largest blood pressure trial ever conducted on older adults found, why too low can be just as dangerous as too high for people over 65, what your numbers should actually be based on, and what 3 questions every senior should bring to their next blood pressure conversation with a healthcare provider. This information is not obscure. It is published in the New England Journal of Medicine, the Journal of the American Heart Association, and the Guidelines of the European Society of Cardiology. It is sitting in the medical literature. It simply has not made it into the plain language conversation that seniors deserve to have. Until now, this channel is built on one commitment: taking published medical research and translating it honestly into plain language for adults over 50. Subscribe so you never miss a new video. We upload daily because your health deserves consistent, evidence-based information. And if someone you know is managing blood pressure after 65, share this video with them. What follows could genuinely change how they understand their own numbers. To understand why 120/80 is not the right target for every senior, you first need to understand what blood pressure actually measures and what changes in the body after 60 that makes the arithmetic different. Blood pressure is measured in 2 numbers. The top number, called systolic pressure, measures the force your heart generates when it contracts and pushes blood out into the arteries. The bottom number, diastolic pressure, measures the pressure in the arteries when the heart is at rest between beats. For decades, the standard target used by most clinicians was a systolic pressure below 140 millimeters of mercury and a diastolic below 90. That was the number people were treated toward. That was what most doctors considered controlled hypertension. Then came a landmark study. In 2015, the National Heart, Lung, and Blood Institute published the results of the systolic blood pressure intervention trial, known in cardiology as SPRINT. It was one of the largest, most rigorous cardiovascular trials ever conducted on blood pressure. More than 9,300 adults aged 50 and older were enrolled. All had elevated systolic blood pressure and at least one cardiovascular risk factor, but none had diabetes or a prior stroke. Participants were randomly assigned to one of 2 treatment targets. One group was treated to get their systolic blood pressure below 140, the standard target that had guided clinical practice for decades. The other group was treated to a much more intensive target, systolic pressure below 120. The results were striking enough that the trial was stopped early, before its planned completion date, because the evidence of benefit in the intensive treatment group was so clear that it was considered unethical to continue withholding that treatment from the standard group. What SPRINT found, published in the New England Journal of Medicine, was this: treating to a target below 120 rather than below 140 reduced the risk of major cardiovascular events, heart attack, heart failure, stroke, and death from cardiovascular causes by 25%. It reduced the risk of death from any cause by 27%, and it reduced the risk of heart failure specifically by 38% and cardiovascular death by 43%. These are not marginal differences. These are outcomes that represent the difference between people who survived the follow-up period and people who did not. The SPRINT trial is the primary reason that the 2017 American College of Cardiology and American Heart Association guidelines updated the threshold for high blood pressure from 140/90 down to 130/80, and why those guidelines now recommend that most adults, including most adults over 65, aim for a blood pressure below 130/80, not 140/90 as previously recommended. Harvard Health published a clear summary of what this means in practice. The previous guideline specifically allowed a higher threshold for people aged 65 and older, treating blood pressure only when it exceeded 150/80. The new guidelines eliminated that age-based exception, not because age doesn't matter in blood pressure management, but because the evidence showed that the cardiovascular benefits of better control applied across age groups. So if you or someone you know is over 65 and was told years ago that 150/90 was acceptable, that guidance is outdated. The research has moved on. But here is where the picture becomes more nuanced. And here is where the 120/80 myth cuts in the opposite direction for many seniors. Because while the SPRINT data is compelling and the updated guidelines reflect it, the full clinical picture for older adults is not simply lower, is always better. And this is the half of the conversation that gets lost. After 65, and particularly after 75, a second set of risks emerges. Risks that have nothing to do with high blood pressure, but with blood pressure that has been pushed too low. The condition is called orthostatic hypotension, and research published in the Journal of the American Heart Association found it occurs in 5 to 30% of people over 65. It is a sudden, significant drop in blood pressure that happens when a person moves from lying down or sitting to standing upright. When blood pressure is running very low, whether from aggressive medication, dehydration, or both, that transition from sitting to standing can cause a rapid drop that the body cannot compensate for quickly enough. Blood flow to the brain drops momentarily. The result is dizziness, lightheadedness, and sometimes a complete loss of consciousness. In a senior, that fall is not a minor inconvenience. Research is consistent on the consequences. Hip fractures, head injuries. A fracture in a person over 70 frequently means surgery, immobilization, and a recovery period that permanently alters independence and quality of life. And published data from the American Heart Association confirms that dropping systolic blood pressure rates had the strongest association with frailty levels and the number of falls recorded in the prior year among geriatric patients. The risk of pushing blood pressure too low does not end with falls. A Science Direct review on elderly hypertension published in 2024 identified a specific concern for people aged 80 and older. When blood pressure is brought down very aggressively in this age group, some experience acute kidney injury. The kidneys of an 80-year-old have typically lost a portion of their baseline filtering capacity compared to a younger adult. They rely on adequate blood pressure to maintain the perfusion, the blood flow, that keeps them functioning. Push systolic pressure too low, and filtration falters. And then there is the brain. Published research in Science Direct confirms that orthostatic hypotension, blood pressure that drops when standing, is associated with cognitive decline and dementia. One meta-analysis estimated that orthostatic hypotension increases dementia risk by 21%. The mechanism is straightforward and devastating. The brain requires a constant, reliable supply of oxygenated blood. When blood pressure drops below the level needed to maintain that supply consistently, particularly in a brain that already has some degree of age-related vascular change, cognitive function is compromised. Over time, that repeated compromise contributes to accelerated deterioration. So here is the picture in full. Untreated or undertreated high blood pressure in seniors carries serious risks: heart attack, stroke, heart failure, kidney disease. The SPRINT trial quantified this with extraordinary precision. But blood pressure pushed too low in seniors, particularly the frail, the elderly, and those over 80, carries its own serious risks. Falls, fractures, kidney damage. Cognitive decline. 120/80 is not a universal target. It was never meant to be. So what is the right target? And why does the answer differ from person to person? Multiple international guidelines have wrestled with this question in recent years, and their conclusions share a common principle. Blood pressure management in older adults must be individualized. It cannot be governed by a single number applied to every person over a certain age. The 2023 European Society of Hypertension guidelines recommend a target systolic pressure below 130 for adults aged 65 to 79, with the option to reduce further to below 130 if tolerated. For adults aged 80 and older, the same guidelines recommend a target between 140 and 150 millimeters of mercury, deliberately higher than the target for younger seniors, to protect against the risks of overtreatment. The Japanese Society of Hypertension's 2025 guidelines went further, specifically recommending that treatment decisions for older adults should not be made based on chronological age alone. Instead, they introduced a functional classification system. A 77-year-old who is fully independent, physically active, and cognitively intact is treated differently from a 77-year-old who is frail, dependent in daily activities, and at high fall risk, even though they share the same birthday. This is the concept that Harvard Health summarized as individualized targets. And it is the concept that should govern every blood pressure conversation a senior has with their healthcare provider. The factors that matter in determining the right target include current blood pressure medications and their side effects, particularly dizziness on standing, the presence of frailty or significant fall risk, kidney function, the presence of diabetes, which influences both the risks and the management, the patient's own experience of symptoms, specifically whether lower readings correlate with dizziness, fatigue, or cognitive haziness, and the patient's personal goals and values, which the AHA 2025 guidelines explicitly include through the concept of shared decision-making. This is not a reason to abandon blood pressure treatment. The evidence that uncontrolled high blood pressure damages the heart, the brain, the kidneys, and the blood vessels is overwhelming and decades old. Untreated hypertension remains one of the most significant modifiable risk factors in all of medicine. What is a reason to have a more complete conversation, a reason not to accept a single number as the permanent, universal answer, and a reason to understand that the goal of blood pressure management in a senior is not to hit a specific reading on a machine. It is to protect the heart, the kidneys, and the brain, while not creating new risks in the process. Here is your practical framework for the next blood pressure conversation you have with a healthcare provider. 3 questions. Write them down. The first question, what is my personal blood pressure target, and how is that target determined for me specifically? Not what the general guideline says. What was decided for you based on your age, your functional status, your kidney function, your fall risk, and your medication history? If the answer is simply below 120/80 for everyone, that is an incomplete answer for a person over 65, and this conversation is worth having further. The second question, when my blood pressure is measured in this office, does the reading account for white coat hypertension? Research confirms that many adults have significantly higher blood pressure readings in a clinical setting than at home, due to the stress of the appointment itself. The American Heart Association acknowledges this phenomenon and recommends home monitoring as a complement to office readings. A single clinic reading that triggers a medication change may not accurately reflect the actual blood pressure picture. Ask whether home readings have been considered. The third question, are any of my current blood pressure medications contributing to dizziness when I stand up, and has my fall risk been assessed? Orthostatic hypotension, that dangerous drop on standing, occurs in 5 to 30% of older adults on blood pressure medications. If it has never been tested for, it may be occurring without being recognized. A simple test, measuring blood pressure lying down and then again after standing, can identify in minutes. These 3 questions do not require a medical degree to ask. They require knowing that the conversation is worth having. And now you know, blood pressure is not a report card. It is not a number you pass or fail. It is a dynamic biological measurement that means different things at different ages, in different bodies, under different conditions, and that must be managed with that complexity in mind. The 120/80 standard that has been repeated for generations served an important purpose. It raised awareness that blood pressure matters, that uncontrolled hypertension is a silent and serious risk, that getting a reading checked is worth the 2 minutes it takes. But for a 70-year-old managing multiple health conditions, taking several medications, and trying to remain independent and active, that single number was never the complete answer. The complete answer is individualized. It is based on the full picture of who you are and what your body needs. And it requires a conversation, not just compliance with a universal standard. Now you have the information to have that conversation. If this video gave you something valuable today, a clearer picture, a better question to ask, something worth sharing, subscribe and hit the notification bell. We upload new evidence-based health videos daily because your health deserves consistent, honest information. And leave a comment below. What has your healthcare provider told you your blood pressure target is? Your experience in the comments might give someone else the confidence to ask the questions they have been sitting on. Take care of yourselves.